Hi, everyone, and welcome to this episode of Office Hour. Today's session is titled Prior Authorization Expands into Traditional Medicare, and we're so glad you've joined us. So, CMS recently announced the WISER model, bringing prior authorization to traditional Medicare fee-for-service for the very first time. This pilot program begins in January 2026 and will reshape how outpatient services are reviewed, approved, and reimbursed in 6 states. We brought together a panel of SMEs with deep experience in customer success and revenue cycle strategy to unpack what this means for providers and healthcare organizations. So let's take a moment and introduce ourselves. I am Stephanie Chang, Associate Director of Client Success. I work closely with health systems and provider groups to support implementation, optimization, and success across the revenue cycle, especially around prior authorization and automation.
Hi, I am Stephanie number two, Stephanie Solich. I am VP of Revenue Cycle and Strategy here at Infinix, and I am in the Midwest region.
James Beecham, also Vice President of Revenue Cycle and Strategy based in Raleigh. And along with Stephanie and the rest of the team, we're focusing on operational strategies that help reduce denials and boost access to care, obviously to help optimize reimbursement, especially in the face of policy changes. So thank you for joining us today.
So in today's conversation, we're going to explore what's actually changing under this WISER model, which services are impacted, and how the providers can prepare both operationally and strategically. So we'll talk about the potential benefits, the risks, the role of AI, and how to navigate the prior authorization process in a new Medicare landscape. As always, we'll leave time at the end for questions, so please feel free to drop in your questions in the Q&A panel during the session, and we'll get as many as we can. So let's get started with the basic. So Stephanie, number two, number one, what is the WISER model, and how is this shift into Medicare fee-for-service such a big deal?
So the quick basics are that it's a 6-year pilot focused on 6 states, which include my home state of Ohio, along with New Jersey, Arizona, Oklahoma, Texas, and Washington. And it also targets specific services that they've identified. It's interesting that it's the first time that the technology vendors instead of providers are participating in a CMS model. So this is focused on the vendors who do prior authorization and have AI and ML. My take is it's a smart move by CMS to take advantage of that technology that commercial payers already have. But CMS doesn't have to build it, and the cost is low risk because the tech vendors are going to take a chunk of any waste reduction / savings that are identified through that technology. And it's a big deal because it's also the first time CMS is scrutinizing itself with fee-for-service in this fee-for-service area versus the private carriers. Stephanie, number one. Can you tell us about the types of services that are targeted under the model, and why do you think CMS selected them?
Yeah, under this model, of course, CMS is primarily targeting high dollar, high volume services based off of commercial payers, like you said, that's already built out that platform there. And historically have shown variability in utilization or questionable medical necessity, right? Kind of eliminate the waste and making sure that the patient's getting the services that they need. So some of the impact services is around neurological and pain management services like injections or stimulation nerve stimulators, surgical and orthopedic procedures around like wound care and tissue services, that's impacted there.
Can you? Are you still sitting? Oh, can you walk us through how this new process is going to actually work in practice? Do you have any idea?
So there's about like 6 steps there. Of course, if you dealt with commercial payers, you kind of have it nailed down in terms of what you need to do to get prepared. One is service identification and PA triggers. Like I mentioned, for those services that is going to be the top of mind within that 6 states. So Identifying the patient need, a service, and that's on the CMS list requiring prior authorization. Example like spinal procedures, outpatient surgeries, and around like DMEs. Step two is, of course, gathering those support medical documentation to support that prior authorization process. Think office notes, imaging reports, test results, prior treatments attempted, and evidence supporting the medical necessity. And then you'll be submitting that prior authorization request to Medicare administrative contractors, MAC for short, electronically or via fax or portal, depending on your system and your contracted workflow. So step three, of course, then MAC reviews the timeline, and then they are looking at averaging 10 business days to review the information that was given and provided for the prior authorization requests. And through expedited requests are available when delays could seriously jeopardize the patient's health. So once MAC can review the request, you'll get an issue decision letter. It's either affirmed or not affirmed, which is approved or not approved. If it's approved, you're okay to schedule your service with the patient. If it's denied, of course, you're going to have to kind of jump through some hoops there. Work with the ordering provider and get you the authorization or working through the alternatives there. And then just 4 to 6, we're going to do some communication, scheduling your patient. 5 is going to be post-service claim submission, making sure your back-end revenue department has a wealth of information like the tracking number or reference number, effective dates within that PA and the services, so that your claim with the prior authorization will then be typically flagged for a faster payment and are much less likely to be denied later for lack of medical necessity, since it's already been done in the front end. It's also recommended to save that information for a minimum of 6 years to make sure that it's easy to retrieve, easy to reference, work with a prior authorization, workflow automation, so that all that information is documented back in your EMR system for reference in a later time if need be. So with all that said, I know there was a lot of steps that happened. James, what role will AI and third-party contractors play, and how do you see this impacting workflows or decision transparency?
Yeah, Stephanie, this is important. I mean, this definitely falls within the strengths of Infinix and our prior authorization platform and other vendors, as AI will be used to automate the review process for those selected services by analyzing claims and clinical documentation to determine just not only just medical necessity, but the appropriateness of the services and the compliance with evidence-based guidelines. These AI functions will include automating the prior authorization processing. A lot of that is done manually today within many organizations. Those prepayment claim reviews, the data triage and flagging if claims are likely to be inappropriate, and decision support for clinical reviewers. And Stephanie, it's important to note that although AI is being employed, it does not make the final decisions independently. CMS will require licensed clinicians to review and validate these determinations, which ensures a human in the loop model. So they're not enforcing that we just rip and replace the manual intervention of the prior authorization workflow. It's just we're going to be integrating AI into the process. And the role of third-party contractors or technology vendors such as Infinix is that for the first time, private vendors and not MACs, as we've discussed, will be responsible for administering this program. And so the responsibilities of that include, and this isn't an inclusive list, but they're operating those AI-enabled platforms for prior authorization and prepayment review. They provide technical infrastructure and workflow tools to those providers. It ensures clinical review teams oversee those final determinations, and it meets the CMS standards for accuracy, provider satisfaction, and clinical compliance. And I think Stephanie, number 2, touched upon this earlier, is that there's a shared savings, which incentivizes cost reduction. So there is a couple benefits and some challenges. One of which, I feel in my research, being that this is relatively new, is that it's going to streamline the prioritization process. AI could, not will, but could potentially speed up the approvals for straightforward cases. In doing so, that's going to reduce the administrative burden. It will help the automation of document review. Right now, that's manual in many cases. So the time spent reviewing manual chart submissions should improve. Again, just think of the workflow, time and effort, prior authorization, the team, the morale, the number of people that organizations employ to do this work. And then coincidingly with predictive analytics, it helps providers prepare for approvals and denials based on historical platforms. So more insights that may not be gleaned today from those manual processes. And then Steph, you had asked about decision transparency. A couple risks there. One is, are we potentially working in a black box? It's sometimes difficult to understand how AI will potentially flag services inappropriate unless there's clear audit trails. We do know, having worked in this space, that there's vendor variability. Not all vendors and not all technologies work the same. So there might be some inconsistency in decision-making between the regions, as Stephanie number 2 alluded to, right? This isn't within a particular region, it is spread out. So things may vary across those markets and vendors. Potentially the appeals process, they'll likely need new procedures to, how do you challenge an AI flag denial? Maybe that perhaps will add a layer of complexity. So there's one more I want to talk about. It was about the gold card. Some of the benefits could be, in addition to the challenges of a learning curve and workflow integration, for those providers that qualify for exemptions, if they should hit a 90% or higher historical approval, they'll benefit from what they're defining as a gold card exception, which will be explained here in a second by Stephanie number 2. But others that don't qualify, less than 90%, will have to face those ongoing review cycles. So again, a lot of information's out there, a lot to be determined. But it's exciting that we're looking to leverage, automation in a historically manual workflow process. So I'm going to turn over to Stephanie, I think number 2, and to expand a little bit on that gold card process.
Yep, thanks. Gold carding is exactly like it sounds. If a provider is good enough and smart enough, they get special privileges. They'll look at that affirmation data that the other Stephanie mentioned, not the Stuart Smalley type of affirmation. Knows what that remembers him. But it's how often claims are affirmed or confirmed without extra issue. Some commercial payers like Aetna, United, and Cigna, the big guys, have had gold card programs in place already. And Texas, which is one of the states in this new CMS Wiser model, has already required commercial payers to have a gold card program for a while. So that's Texas might be a little kind of a special situation there. It might be a little easier for some of those providers. So what can providers do now to qualify for that gold card? Try using clinical decision support tools at the point of order, centralized analytics to monitor outcomes, and ensuring thorough documentation, like basic stuff that I'm sure everyone already is working on. But those kind of things are a good start and to get you that gold card so you can be cool. James, so since this model starts in 6 states, what if you're outside that test group? Should you care, and how should you prepare if you do care?
Yeah, you definitely want to be mindful and pay attention to what is happening within this pilot group, because as we know, CMS is currently testing this as a potential national precedent. Wiser, as we explained, but it bears repeating, it's a CMS Innovation Center pilot. And like other models, ACOs and bundle payments, those successful pilots scaled nationally. So if Wiser does end up reducing Medicare costs and minimizing inappropriate service utilization, in all likelihood, it's going to expand beyond the 6 states. So providers in those non-pilot states have a little bit of a heads up and should expect a similar AI-driven prioritization model in the future, either from CMS, commercial payers, or both. And again, it's allowing the providers in the non-pilot states to prepare for a fundamental change in how prioritization and claims reviews are going to be handled. Even outside of Medicare, commercial payers are already investing in similar AI-driven processes, and this signals a market-wide trend toward the utilization of automation in pre-services, and it's, again, not just a regional test. As the first program outsourcing utilization management to tech vendors, this is definitely going to influence how other payers structure partnerships with AI vendors, which could potentially change how providers interact with the entire payer ecosystem. For a provider in a non-pilot state, you've got to prepare. You need to look at your current workflows and map that current prioritization and prepayment review process and identify those gaps in data quality, perhaps your documentation standards, your EHR workflows, as those could create friction with how an automated review system, works. You want to look at your AI readiness. Not everyone has embarked on their AI journey. So even if you're not mandated now, beginning and looking at adopting an AI-friendly clinical documentation practice to prepare for these future review models should be in your best and short-term interest. Looking at AI, RPA, generative AI, all the different automations for pre-check claims and potential denial risks before submissions. You probably want to engage vendors early, not meaning you have to adopt and deploy, but you want to potentially look at or track which technology vendors that CMS selects for the WISER model. Those particular vendors may soon partner as a result with commercial payers and expand into those other states. So, great references, with ones with who to work with, and potentially start now to build relationship with these companies to help influence, right? We're all strategic partners in this. So we can provide some education and insights to help influence those future rollout and strategies. So bottom line, even if you're outside of the WISER states, this is a great opportunity to build and follow a blueprint for the future of Medicare and the broader payer policy. And to summarize, just preparing now will help reduce, not eliminate, but should help reduce future disruption, should improve operational agility, and help position your organization as a leader in navigating AI-driven healthcare workflows. So it's a good thing, and Infinix is exciting to be at the forefront of this opportunity.
Awesome. Yeah, we covered a lot today, and we're in July right now. We still got some time, right? This isn't going into effect until January. So take some time, prepare for it as this goes into play in January 2026. Year flies by. Well, thank you both for jumping on as well. And thank you everyone for joining our session today. We truly appreciate you taking the time out of your day to be here. We hope you found this session valuable and insightful. And until next time, take care.